the data science at Bluesquare. Bluesquare is a Belgian organization where we are doing and working on a health information system strengthening through software development, and I'm leading the team in charge of data analysis as part of Bluesquare. Simon asked me to give some elements and some thoughts on how we think HIS can contribute to integrated outbreak analytics. And so I'll just present two ways in two moments. First, I'll just tell a bit more about what we mean by health information systems and what are new and recent progresses that have been made so that we have new opportunities to use this data. And then I'll show some examples and reflect a bit on how that could be used in integrated outbreaks and analytics. So, oops, what's happening here? Okay, so just as a starters, the way and what we call health information systems, we use a very broad understanding, both in terms of what type of systems and what type of data is being used. In the programs where we work at Bluesquare, we use, and we support the utilization of data for monthly health facility reporting. So typically what DHIS2 will be using, but also weekly surveillance. We've been using at some point with distribution centers management data, so on stocks of drugs and flows of drugs going to facilities. Health financing reports can also be included in that. And so really the idea is to manage a variety of data system of data flows that flow through the health system and make sure that it can be used properly. Also, one of the points is, and that was part of the title of the presentation of the session, is there is this focus around DHIS2 that is a very preeminent platform, but there is still a lot of other software and technical platforms. And I just want to make clear that the variety and the diversity of software and platforms that are being used in the information system is not something that we care about, or it's not something that is an issue. And that it's not about the tool itself. It's about the data that is going to be used, and I'll say a bit more about that. If you work in global health, and I've been reading around a bit about health information system, the chances that the common knowledge is that health information system data are not so difficult to use. So here are the quote from the Health Metrics Network, 2008, that starts to be a bit old now, but a publication on standards for country health information systems. And here, there is this focus on the an ability to analyze the data and to use the data that is being collected, and also the fact that it's a burden on the health of workers. And so there is a bit of a disconnection here between the investment that is being made in having people spending a lot of time collecting data, collating data, entering it, but the ability to actually use that data on a day-to-day basis. But one of the things is that that's not a new thing. This, this is a quote that is very similar in terms of its contents. The health information remains cloaked in collection tools. It's not really used. And that's a quote from a 1989 paper by Emmanuel Decatz on the use of information system in developed countries. And in the 20 years that have passed, the situation keeps being the same. Also, one of the things is that that's not specific to developing countries. And here, this quote is from a 1988 paper about the health information system in France, saying that between 1945 and 1988, there were 3 generations of systems about to account for hospital mobility. And so that's still something that is difficult to get positively and to get right. And it's hard to have a system that allows to have the information that is needed in the format that is needed in the time that is needed. And also, when we talk about long periods, this is the last quote I wanted to share, which is very similar to the precedent. These documents gathered with the methods are incomplete and filled with mistakes, and they are tiring even for the most number-oriented mind. And that's from 1880 reports from a French statistician working in Algeria with colonial statistics. And so you see that it's not like there was something that was gotten right at some point and it's being harder. I think really the state of the situation is that setting up routine systems that collect data, that are able to transmit data so that it can be used, is a very challenging problem, and has always been. And so that's really something that needs to be invented and thought through. This being said, and all those challenges, and this historical perspective being taken, I would say we're not giving up, in the sense that there have been a lot of recent progresses in health information systems, routine systems, that give a lot of new opportunities to use the data and to actually make it work. First is, in the past 10 years, there have been great progress in massive data collection. So we talked about DHIS2 as a platform. DHIS2 is very widely used in many countries. And in a country like DRC, on a monthly basis, you have 16,000 facilities reporting over a dozen of indicators. So that means that over a year, you will have over 160,000 data points with a lot of different data in it. And as a result, and Simon and Aaron will be showing some elements on that, you have, even with low quality of data, even with outliers, even with the issues that we can find, the sheer amount of data starts to make regular statistical regularities appear. And so in terms of surveillance and analyzing this data, even if you have low data quality in a lot of situations, you can still start getting signal and work on signal using the appropriate methods. And I would say this backlog of data that has been now collected over the 10 last years in many health facilities should be managed and should be mobilized to do that. And I'll show some elements in a minute. Second is that these massive amount of data that come from exploded system and balkanized systems, there has been a lot of progresses in making them, in consolidating them. And this happens in two situations. First is in interoperability, meaning having systems that will talk with each other. You could have two DHIS2 systems talking with each other. You could have an EMR system talking with a DHIS2 system and sending the data automatically. Or you could have some import processes or some data sharing processes between systems, so that data, even if it's not collected in the same database or in the same data system, can be consolidated. Second, and that's something that my team is working a lot about, is, there is also a lot of new tools for and opportunities for data integration. And data integration is different from interoperability. What we call integration is ex post, once the data has been collected, having a platform where you can pull different data that comes through different systems and make it integrated, meaning aligning data in terms of space and time, aligning some indicators with each other that are similar, even if they are not labeled the same way, and having this data getting in robustness. And also augmentation, and I'll show the example of augmentation. Augmentation is about adding data that doesn't come from the health system, come from other data sources, but can also talk and be put in the same referential as the health system referential. And so those tools are where the progress is that we're able to do that now very easily with scripted languages like R or Python, and have these augmentation and integration being made routinely, so that when data is updated, you could then update the integration itself, and you can move forward with different data systems, but pulling it together at the end. Thirdly, we have progresses in modeling. There is a lot of new models that have been developed in the last decade on accessibility, forecasting of needs, talking about surveillance, that are possible to run on the type of high-level data and high frequency data that we talk about when we talk about HIS. But also that are very efficient in terms of computation, so that they don't need to be run on super big computers and to have them run during a couple of days, but they can be productivized, run routinely in the cloud in a couple of hours. I'll show an example in a minute or so. But this means that in terms of detection, in terms of surveillance, you have improved capacity to be running performance algorithms on the data that you are managing and willing to use. And finally, and that's not specific to health information systems, but there has been great progresses in data visualization. Meaning you have a lot of tools like Tableau, Power BI, or other BI tools or visualization tools that allow to do interactive visualizations that are very useful when you talk about a health system that has many dozens or thousands of health facilities trying to manage different levels of aggregation, different frequency of data collection, different series, and a couple dozen of series. It's very easy for an analyst, for a decider, to get lost in that amount of data. And so those tools of visualization are really a way to put that data really easily at the fingertip of the users. And the experience that we have is there's a very good accessibility of those tools. People are willing to be able to learn those tools for data consultation and data visualization, and learning as users, not maybe being the one that is programming the dashboard or programming the graph, but having access to the data through those tools. And what you see on the right here is a picture that was taken in Sankuru a couple of weeks ago during a review of the National Malaria Program there. And what they are using is the tool that I'm going to show in a minute. That is a Tableau dashboard that we've made integrating data from multiple sources for the PNLP. And so what we see here is that there is an ability, even for quite advanced tools, to be used, but also to support discussions. And the person you're seeing here is Meshach Mutombo. He's really leading a discussion based on the data that has been collated, that has been consolidated, and they're able to use it during those supervision. So I wanted to take a bit of time to show you three advances, three examples of data integration and of mobilization of health information data, just to give you a sense of what, give more concreteness to what I've just shown. First one comes from Cameroun. It's a work we've done with a malaria program in Cameroun. And here what you see, I'll just go through the type of data that we've been able to integrate. First, what you see here is you have data that comes from their malaria program, the malaria control program. So you have a variety of modules with a variety of indicators in each of them. What we've been able to do is also to sorry, okay, oops. Of course, that happens. Okay. What we've been able to do was to reconstruct the series since 2015. So you have now 7 years of data on all of those series. You've been able to also show the targets that have been set by the MOH for these different indicators, so they can monitor the performance or have a control group. What's happening also is you can, go on, this is a quarterly aggregation, but you could go on monthly aggregation or yearly aggregation, depending on what you want to do and the granularity of what you want to have. And you can also, look at a country level, region level, or district level. And in some dashboards, we are also able to go to facility level. So you have this ability to vary the scale of what you're looking at. And as I was saying, that's a very good way to be navigating the data and not being lost in dimensionality. Here again, you have integration between the spatial way of looking at data and time values, and you can filter in a dynamic way between those different aspects. And so that's a tool that is being used by the PNLP now to monitor the data and do monitoring evaluation. What's been added to that is here we've added also in the same space data that comes from a different systems. So here we've already aggregated historical data with current data, and there is a different system that is weekly surveillance of malaria. So that's weekly data that is going through a different system. And what we're looking at here is we've also added rainfall statistics that we extract from satellites imagery from NASA on rainfalls, and we're able also to have the average on the past 10 years, and in red here, and in blue you have actual precipitation during the year, so that they're able to see also the data that they have for the weekly surveillance aggregated in the same time space, in the same zones and borders as for what they have in the health information system with climatic data, and they are to support understanding what's happening in terms of malaria trends. And so you have already a couple of different data sources. What we've added also, and what is being used, is adding data on resistance to malaria, to insecticides. And so here you have the same thing. You have a map of Cameroun where you see the different surveys that have been occurred in 2019. And you can go back in time, where the different surveys have been happening and have, some sense of the results. And here you have the overall trend of what's happening. Maybe not the best visual you see today, but that's, what we're working on with for now. So you can see that in that sense, you can mobilize health information system data, you can consolidate it, consolidate the different flows, and then have augmented with climatic data, with surveillance data on a vector, and have a way, a unified and integrated, that is the word for the group, integrated framework of analysis to follow those different elements and do some surveillance here. So another example I wanted to give was from DRC. Here we are on a slightly different scale. It's a dashboard also for the malaria surveillance. Here, two things I wanted to show, three things I wanted to show. One is here the ability to combine data that is, rates, proportions on some prevalences and lethality rate, and you can have that, and you can move those and select those here. Some, amounts and volumes of activities happening, and there you have some stock and resources information. So what you're able to see, visualize in one space here is at the same time the activities and the health-seeking behavior and the ability to provide services in the facilities. You have some, population-controlled proportions to follow mortality, lethality, to follow, a bit of the distributions of the different values that you're following here, and you also a sense of preparedness here, and you have a sense of what's happening in the health facilities in terms of resource. And so you have three dimensions that allow you to understand what is the activity of the health system, what are the characteristics of the activities that are happening, and how good we are prepared to tackle different issues. And here again, all of these, you have a list of values that you can use here. Another aspect, and I talked about modeling a bit earlier, and what you see here is a model of accessibility of health services in DRC. So it's a type that what you're seeing here and what the color shows is the proportion of population in each health zone that is able to access a facility with malaria services in less than 30 minutes. We can vary that from 30 minutes to 1 and 80 minutes or 1 and 50 minutes if that's of interest. And the size of the bubble that you have here is the size of the population that is being served. You can also have size of the population that doesn't have access, in the time that you are interested in. If you want to ensure, good accessibility. And here you have a distribution of, how accessibility progresses depending on the definition that you give. So these are quite advanced models that run and are a bit heavy to run, but now we have productivized them in the cloud so that you can update them on a monthly basis. And here you see I can select, this was February 2021. I can look at what's happening in April 2021. And it takes approximately a couple of less than an hour to run for a given month and update that information. So that's something that, is tractable in a working environment for an administration. And finally, that's something where, because all the friction layer, underlying friction layer, where we compute the travel times, comes from data that can be automatically updated. You can also account for shocks like floodings, like conflicts happening, and you can close some roads. You can do this kind of modification. So you can update the model on the fly based on the actual situation in country and have that happening, and compare it to your HIS data, directly to the HIS data that you have. And finally, on this dashboard, one that is interesting is work that has been starting, and that's really work in progress, and a new way of thinking is integrating some surveillance. And I've showed the ability to have some targets. And here, what's starting to happen with a PNLP is we are looking at, on a regular basis, the number of cases that we've seen. So we're not in 2022, and we look at the third quartile, which would be threshold for epidemic outbreak of malaria, and then the doubling of the average. So those are the thresholds that want to be kept in place. And here we also compare with former years of data that have been seen. And here you can classify and look on the map about do I think that I have an abnormal situation based on the definition, lethality higher than 1%. I could take a definition that is doubling over the period of the number of cases of malaria, or I can look at here having a number of cases that is higher than the third quartile of cases on the period. And so that's something that you can look at and have a very visual way of looking at where outbreaks are happening. So in the interest of time, I won't go into the last one in much detail, just showing that's one that you can access, and you'll have a link in the presentation that we'll be sending. And that's also a dashboard that allows the monitoring of 22 outbreak-prone diseases in DRC. And here again, we've reconstituted the series since 2016 on a weekly basis. So all the data is now accessible. There is some processing and some ways to visualize it so that it can be also used for surveillance and outbreak investigation. So coming back to the presentation, I would just want to move to question that Simon was asking me is how HIS could be used for integrated outbreak analysis. Four really main domains for me that I think are of interest. First is early warning, and working on that massive data, we're able to detect excess in morbidity or mortality, identify communities with abnormal healthcare patterns with low access to certain services. We can look at preparedness, looking at where drugs are available, where certain infrastructure are available in the services, and monitor, the access of communities to those health services. Then there is the outbreak impact evaluation, meaning you can look at when you have an outbreak in some in a space, what is the impact on the access to healthcare, and as Aaron will be showing also, the secondary impact on death and morbidity in population based on your HIS data and on the strength that you can borrow from past data, historical data. And then there is a support that HIS can provide for data collection and communication. And I think that's also an important point in terms more of systems. But in those HIS, in those health information systems, you have master facility lists, you have metadata that can be used and borrowed to plan new data collection programs. The good thing with that is if you use the same metadata, the same codes, you can send back the data and strengthen the data in the HIS. Second thing is, as you have tools to share data and to communicate with deciders, this can also be used. And in the dashboards I've showed, we've worked with Simon already, and that's something that can be made, add some results from some qualitative interviews. For example, you can have some key facts that are key finding from the surveys that can be shared in the same space in the same tool, in addition to all the other evidence that is being compiled in that place. And finally, that's also a sense, and coming on my end more from an HIS perspective, the question is really what we can do, how HIS can be used for integrated outbreak analysis. But we can also send the question back, and what I'm showing here is really the model in which we work at Bluesquare, not really for data integration, but the way we work is we use the data integration and analytics and visualization that you saw as a way to provide information that then will be used for microplanning and used for vaccination campaign or malaria bed nets distribution campaign, etc. But then when the data is collected during those campaigns, these could be sent back to a georegistry if you found a new health facilities, or you can identify quality data issues, or you can identify populations, places where or you have been measuring the needs for your microplanning and looking at the population, and this can be fed back and strengthen the data system itself. And so I think we should really have the discussion towards the back and forth between health information system, routine systems, and how they can be mobilized and strengthened, but also how additional data elements can join that integration effort that we make to have complete information. Thank you.
Thanks so much, Gregor. I'm going to enchaîn and let Aaron explain. So we'll have, for those who joined a little bit later, we'll have also then Aaron talk a little bit about some of the how he is actually doing some of the analysis of the data, and then I'll explain how a couple of case studies on how we're using that. Aaron, are you with us?
Yeah. Hi, everybody. So thanks, Gregor, for the introduction about the infrastructure and the data systems. So based on what he has described, I can just share my screen very quickly. So I will give you a very concrete example of how we have been using the data in the DRC's DHIS2 data, very simple. So the first one you can see here, it is a visualization of the deliveries over time. So here we observe a great increase in the number of deliveries roughly about 10 months after the onset of COVID-19 outbreak, which may reflect a big increase in women pregnancies during the outbreak, especially in this health zone called Nyiragongo. So when you are using this data, it's very easy that you can eyeball those trends once you plot them out. But the question is, how do you make sure that the data is valid? So the first approach, well, the easiest, the most straightforward approach would be to visualize the local facility level data. So thanks to the richness of this data set, we have, as Gregoire just described, we have over 18,000 facilities making their monthly reports. So whenever we saw a trend like this, we can always trace back to the root facility level data. And what I usually do is we can use a map like this one you are seeing here to pinpoint the facilities that had the greatest proportion increase, or however you want to define that, so that we can dig further into those facility level data. And then the next step may be field research to confirm, one, is there really anything happened, or does it make sense to see, for example, a facility around this area to have a over 50% increase in deliveries. That would be the first step as a very easy check to see if you do anything wrong. But that's more of a that's more of a manual check, although that would be very easy if you want to show to your colleague or convince others that you have that you check the data and those are the facilities with the biggest problems. But here are some other statistical ways that we can check the data that I want to share with you today. So last year, Dr. Karen Grapping and I studied missing value imputation methods in DHIS2 datasets. So one huge limitation, as many of you might know, that the routine health information systems, not just DHIS2, they have a lot of missing values and extreme values, partly because those data are reported and collected from each facilities on a piece of paper usually, and they can easily get lost, or the number may be too ambiguous to read clearly. So here there are 7 methods that we are comparing. And the point we are making here is we commented on how poorly the usual missing imputation method techniques are, such as you can see the blue line is mean imputation, the purple line is exclusion and interpolation. And a previous systematic review found most of the papers or research in this field have been using those 2 methods. Though they are commonly used, we showed that those methods can immediately be biased and give you very incorrect inference, even when you have only 15% missing values in the data. So when you get a larger proportion, they are just way off. And besides that, in this paper, we also recommended multiple imputation algorithms, which for sure is the MI, multiple imputation algorithms that can be used to fill in the missing values, and we have shown great consistency and performance of this method in the paper. So if you're interested and your data of a similar format also have missing values, please do take a look, and all the codes are available, and it is actually very easy to implement it in R. I don't want to get into too much statistics or technical details in this presentation, but just from this graph, you can already tell like the black line is the truth. And you can see how the common methods are going offline and how bad your inference based on data can be. Whereas you can see the 2 red lines, which are the multiple imputation methods that we recommend. They still maintain a reasonable level of consistency with the true data. So if you're interested, please do take a look, and all the codes are available. And one last thing that I'm currently working on is to deal with fake spikes in the data. So that's a rather more difficult question. So here's an example of the family planning data in DRC. If we simply visualize original data, so let's go back to the deliveries trend. Like that's Although we still have some up and downs, that's still easy to eyeball a trend of going up at the end of by the start of 2021. However, if you ever had a trend, once you apply it like this, it will be very hard to eyeball anything. So if we simply visualize the original data, our attention will certainly be drawn to those huge spikes, right? However, if we do look into the facility level data, like the map that I showed you earlier, we will find out actually those are fake spikes driven by extreme values. Where do those extreme values come from? They are most likely caused by reporting mistakes. Okay, so how do we know if it is a mistaken reporting? Well, we will never know for sure unless we go and ask the facility manager, but that will be a very time-consuming process. But we can actually guess at a pretty good rate by comparing it to the historical values. For example, if a facility had reported only about like 20 cases a month in the past 3 years, and you don't believe there's anything extreme going on in that health zone, but suddenly in this month, it reported 2,000 cases instead of around 20 in the past, right? So instead of saying something really happened there, chances are when the data is recorded or input into the system, the clerks just mistakenly added 2 zeros or added to something into the cell, and that will cause the problem of those missing spikes. So ideally, if you could manually go through the data points and confirm with the facility managers, you will get a very, very good data set of very good data quality. However, as in our case, we have 18,000 facilities updating every month, and we have over, I would say, over 30 indicators that we are checking at a daily basis, including like diabetes, family planning, deliveries, etc., etc. It would just be impossible. Even if we had a team of like 100 people, it would just be impossible to check that manually. So that's definitely a need for some statistical methods. So this table is a summary of what WHO recommended, basically. So there is a guideline, WHO guideline. There is a, I believe there is a series of 3 publications that WHO had made recommendations on which indicators you should look at in your country DHIS2 and how you should evaluate if a point is outliers and if that point needs further investigation. So in the DRC case, we can see these common indicators, they have a pretty good rate of in terms of the number of outliers. So if we have it under 2%, that's pretty manageable. However, that's just the number of outliers. That doesn't mean it cannot drive the fake spikes. For example, going back to the example of you have a facility that had been reporting 20 cases in the past. If you see reporting 200 cases or it's reporting 2,000 cases, that makes a lot of difference when you're just plotting data. However, just for a human being, if you're looking at the data, you can easily tell that no matter is 200, 900, 2,000, it's likely to be a mistaken reporting, right? So that in this case, it's also very helpful to assess if we know the true data, i.e. the average cases per facility with the outlier removed, how does that look compared to the original one when we have all the perhaps mistaken data included? And we can see there are some indicators that performed systematically worse than the other, especially in the DRC case though. It's probably different set of indicators for other countries, but just in the DRC, family planning, diabetes are really bad. And then the vaccination, all new cases, and some other indicators, they performed relatively good. So for example, in this one, this sale of antenatal care, the first antenatal care, it's saying that even if we do not do any handling of the extreme values, we will get about 23 cases a month per facility. However, the truth is about 2021. So that's not a lot of difference compared to the other cases where we might have over 30% differences. So how we approach this question is that we have divided the space of contamination into the indicators that are slightly contaminated, moderately contaminated, and heavily contaminated. So the small percentage in the bracket shows if you have the outliers. Okay, I will go back to the question later. So, so say we have the indicator of new client visits. So slight contaminated will be half lower than 2% outliers, and then 2 to 5% outliers, and greater than 5% outliers respectively. And we show under different circumstances, there are methods that will outperform the others in each of those zones. So that's basically another way of showing you which method you could use when you observe different combination in the data. And then finally, those codes are also widely available in R, in Python, in Stata, and they are very easy to implement, and we can share the entire process of how we approach that too. Okay, thank you. So that's my presentation. So going back to the question.
Erin, are you okay if I complete the presentation and then we go through questions?
Yeah, of course, of course.
Because I think also, Mary-Emily, something we might be able to show a little bit in terms of the qualitative stuff that complements.
Sure. Sounds great.
Thanks. Brilliant. And so I'm just going to quickly finish up and hopefully because we want to have time for questions for everyone. So how does this kind of work in terms of what we look at in terms of programming and integrated analytics? So we work with multiple actors in the DRC through the Integrated Analytics Cell, and we've used this data for measles, for Ebola, for malnutrition, for the impacts of COVID, looking at sexual and reproductive health, and looking at anemia as well across different ways. So for example, when we looked at, let me just hide my floating control. When we looked at the measles outbreak, we first had information from local health authorities, not through the DHIS2, that there was a particular rise of measles. So then the next step was to try and understand the underlying causes. So we went back to the DHIS2 and looking at both where the outbreak cases or the increased cases were coming from of measles. And we asked Erin, from Bluesquare to Erin to pull that data and then to look at vaccination rates, but also look at other possible health risks in those areas and comparing them to the national. Then we did qualitative analysis to understand the why. This included mapping of events. So for example, Mary-Emily, if there had been a movement of population, and in some of those areas there had been, and then presenting the results locally to local health actors, local community health workers, NGOs working in the area, pretty much anybody who was working on measles, as well as the clusters, for example, to co-develop recommendations. And the link to the presentation, which includes recommendations, is in this PowerPoint. So you have one kind of data that shows us where the cases are coming from. Then we were looking at, my screen's going a little slower, then looking at the vaccination rates. And what we were seeing was these big drops in vaccination rates, for example, in Messina too. One of the things to note is that at this time, we don't have the ability to be analyzing this data preemptively at that low level, like this is a health area level, to work as an early warning. And this is something that we're working with multiple partners to see how we can, including Bluesquare, to see how we can make sure that the Ministry of Health could actually already have that as a warning as soon as that drop comes, as opposed to waiting until that drop equals an increase in cases. What we also look at, so of course, comparing everything against the national, looking at things like malnutrition as well. So also recognizing that the malnutrition rates in that area compared to the national. Again, making sure when we're thinking of an IOA lens, looking at what are the different events that are taking place over time. When did prices change? When did the impacts of COVID happen? When were the healthcare worker strikes? Were healthcare worker strikes potentially influencing reporting or were influencing vaccination rates? So understanding all those different events before we go and collect qualitative data to really understand our context. Understanding what is the profile of the situation. So what are the case ages, ages and gender, vaccination status, potential transmission risks, characteristics of the community. So in terms of poverty, socioeconomic situation, how many people are living in housing and how the promiscuity of the housing situation. Running qualitative studies with healthcare workers and parents, understanding things like, for example, even though postnatal care and vaccinations are supposed to be free, there's always a charge for the service. Understanding that women, the socioeconomic impact of women who need to work in these areas because they are low income areas, in their ability to not continue to take their children to postnatal care and vaccination follow-up because they just can't afford to not work. So really understanding those different factors, the large responsibility of mothers for doing this work and the gender dimensions of that as well are taken into consideration. Also issues about, the impacts of COVID, so recognizing that there has been increase in costs, that the postnatal care sessions that used to be bringing everybody together were now being reduced because of the fact that they weren't allowing people to be in the same room, but also recognizing that, for example, the healthcare worker strike, according to healthcare workers in the area, wasn't having as big an impact because so many of the structures were actually private structures. So again, looking at these different dimensions of population movement. So a lot of those areas had people coming from other parts of the country. They don't have vaccination cards. They don't remember if they were vaccinated. They're young adults. They don't know their childhood vaccination. Socioeconomic situations where there's people living in close quarters, low use of healthcare services, lots of auto medication, high rates of child malnutrition as well. And making sure that we're looking at this, we're looking at vaccination status, vaccination accessibility, vaccination acceptance, and vaccination availability, and understanding all of those different factors as we look at the data from the DHIS2. Just a reminder, of course, we do this through co-development of recommendations. So then the data are presented and we co-develop 16 different recommendations across the different actors over time. So just very quickly, a couple of other examples of how this can be used. So this is looking at an integrated outbreak analytics lens for understanding transmission factors of children under 5 in the 10th Ebola outbreak. So we recognize that there were high rates of children under 5 that were being affected. We did illness narratives and verbal autopsies with parents to understand what was happening. Parents were reporting children sharing injections, children sharing beds. We had infection prevention program reports demonstrating that less than 50% of healthcare facilities even had infection prevention control materials. Household and healthcare worker surveys where healthcare workers reported that they didn't know how to stop transmission among children. And then also looking at DHIS2 data. And what we saw was we knew that free healthcare services had been put in place. And when free healthcare services had been put in place, we were able to look at that over time. And so that's in the bottom left here. And we can see that there were huge increases of up to 200%, in which could be, or an increase of up to 100 patients per month. So 3 patients per day. And we know that the majority of healthcare facilities with nosocomial infection had less than 6 beds. So really recognizing that there was a huge issue in terms of having multiple patients in a healthcare facility at a time. And again, we're not saying this is necessarily causation, but we are seeing correlation and we were able to use this data. At the beginning, we didn't have this data, but what we did was go directly to the facilities and collect with our hands out of the registries to have some kind of idea of the impact of the healthcare facility or free healthcare services, policy. We've also looked at this data through COVID-19, looking at sexual violence rates. And so while these are particular data that are not strong, so we asked Aaron to test for us which provinces the data was good enough to use. But we did see, for example, in Goma, that the increases were tested and that the data was clean enough to say this was a significant change, as Aaron demonstrated on the deliveries rate as well. So we're able to see that. Then again, collecting qualitative data through interviews with women and girls in the same area to understand the factors which were potentially causing that increased sexual violence. Again, family planning. So I won't go into the previous one because Aaron did, but one of the other things that we were able to do is that Aaron was able to model for us what would have been the trend. So this is in the deliveries of under 20 in Kinshasa. So we see that there was a downward trend, but the reality is up here. And so again, we looked at this and then we immediately went and collected qualitative data to understand where was this happening, also looking at the particular health areas. So when we were able to look at the, is it on that? Yeah, when we were able to look at this, we can see the specific health areas. So we know where it's vulnerable. We recognize that these are in particular slums. We work with the Kinshasa School of Public Health as well to say, okay, what's happening there in terms of they have programs for family planning, what's happening in these particular areas for those programming. We organize workshops and presentations where we discuss the data with Ministry of Health and other NGOs to try and see not only about scaling up family planning, but now dealing with all the increased deliveries and what are the programs that will happen to make sure that are we seeing matching the increased deliveries, increased vaccination rates for the first year of the child's life. And so again, making sure we're working with qualitative data, DHIS2 data, healthcare worker surveys data, and understanding different events over time for a holistic picture. We've been able to use it for monitoring of family planning. And lastly, we've used it to be able to identify households of anemia cases to develop a methodology of working specifically with anemia cases in another part of the country. So I'm going to stop there. We have multiple ways that we are using this. Again, using all of these different data sources together has really been brought up within the Ministry of Health to be able to support programming and planning. So I will leave that last slide up, but I'll take it out of screen share so I can see everybody in the last 10 minutes, sorry. So really what we'd like to know as well is like, if there's people on the call who would like to hear more, be more involved in this kind of work, and what would support look like on this? I know we have somebody from the Ministry of Health in Congo Brazza, for example. So is it training? Is it field visits? Is it bringing together different case studies and making those more available? Is it all of the above? And if anybody had other experiences that they would like to share, so that we can continue to kind of build this community of practice, especially in being able to document and support the use of this data. So I will look for hands. Questions, comments? It's very quiet. So Erin, maybe then you want to answer it. Oh, Ruby has a question. Go ahead, Ruby.
Yeah, just to bring it back to basics, I think. Can you, or maybe Bluesquare could talk about the ownership of the HIS data or DHIS2 data or whichever HIS system is being used, and accessing that data and the challenges around that.
Yes, thank you. I think it's a great question. Actually, one that the work that I've been showing is trying to think through. I think this issue of getting access to data that is in DHIS2, or to make sure that only people that should have access to this data have access is an issue, and sharing practices in many settings is getting an authorization, getting some access. Some people even have admin access and some production servers for just a punctual research project or support. And there is not a good sense of management of the governance of data accesses. Now, on our end, one of the reasons we started developing a data integration platform was also to support that type of data sharing, meaning we have a clear setup where data can be extracted in a certain format, and then people that need access to that data can have access to the platform and then use it. So, for example, the work that Aaron has been doing, he has an access to the platform that has been granted by the MOH in DRC. And then we can, give access to certain data sets and decide based on the authorization given who has access to what. And so, in terms of the way that works, I think one of the benefits of integration and the approach that we take is to have this one stop where every actor interested in working on HIS data at large, be it DHIS2 data or other type of systems, through an access, a unified access, can access different series and different sources. And this simplifies the situation for the Ministry of Health, that doesn't have to, manage requests by email, sending some extract of one system and then another extract to another system, can revoke access to the platform when people don't need to have access anymore. And so this the simplification aspect of data integration goes in that direction. And I would just add one aspect to that. It's also, and we hope can support the type of work that Cass and Aaron are doing in terms of supporting local capacities for analysis, meaning as all the code for analytics, all the code for a clean can be implemented on the platform. You could have, you can have researcher working on the type of analysis that Simon and Aaron have shown, and then the country taking ownership of the code, not only the data that keeps in its premises, but also the code can be reused, and in that way, this establishes the creation of these kind of libraries of analytics that can be reused in countries. So for example, we work in that right now in Cameroon with the Global Fund and WHO on an impact evaluation of the malaria program. The idea is to have run that analysis on the platform in Cameroon, so that after the end of this evaluation, the code could be rerun in a period of time, and you could have students from university in Yaoundé come in and use that code, and you could build that capacity. So the ownership is not only for the data, but also for the code and for the analytic model.
Thanks, Grégoire. Yeah, and I think we're also working right now trying to see really how working with the DRC Ministry of Health to say, how do we develop a project that they lead on, that they identify their needs to have the full capacity of this and the analysis and the use and the identification all within the Ministry of Health. Any other last minute questions? Marie-Amélie, I'm not sure if you felt like we answered yours enough. Otherwise, we can let Aaron really quickly.
Hey, I think we can take that offline. It's just that in the example you gave, I understand that you went back to the field to understand what happened. It's just that the DHIS2 analysis comes before. So I would imagine that the cleaning process comes before also. So how would we make sure? I mean, it's also a data quality problem that also relies on surveillance systems, and the surveillance systems need to be strengthened, etc. You can't do everything, obviously. Yeah, I was just wondering, how do we make sure that this data is not cleaned before we actually have time to detect any abnormality?
Yes, so that's a very good question. So very quickly, our take on this is to use the data to drive investigations. So for example, all the methods that we have chosen, they can tell you exactly which cases in which health areas is abnormally high or abnormally low. And you can compare that easily with the historical data and see if you can say with confidence that's a mistaken reporting. We don't need to investigate further. We can just say that that's wrong. We can clean it out. But because of the method also give you a picture of how that look like around across the country, there are some areas which you are not so sure. And then in that case, we use that data to drive the investigation to see if, for example, we can call the local officer, or once we've identified which health areas, we can even have a team to be there to see what's really happening. So the key is we use the data to drive investigation. We do not solely rely on everything that's being cleaned, because as you said, we don't want that to happen without we really having time to investigation. But the other trade-off, the side is that the data is updated every month and we just couldn't do all of the investigations. So there is a balance and trade-off that we have to decide.
Yeah, thanks. And maybe also decentralize a little bit the analysis for big countries like DRC.
Yeah.
Is there a will to decentralize more and get more at the provincial or maybe territory level, training people so they really know their context also, and they would know this kind of information. And also it decouples the number of investigations you're supposed to do, I imagine.
Right, like currently we are doing at national level. So Simone, maybe you can add to this, but I don't know if anyone else in the DRC are doing that at a local level.
Yeah, and I think one of the challenges is, Emily, truthfully, even the capacity at national level is what we're really trying to make happen first, because that doesn't even exist in the sense of, so what we're working with Bluesquare and other partners is to say, how do we make sure that, and we've already said, you know, in our most recent meeting, how do we already at least make one person or two people from different provinces with that capacity, but the capacity doesn't exist in country. And this is something we've talked, you know, we talk about a lot of, we use R, but they're trained, but national partners are trained in EpiInfo, and so they can't, you know, so it's how do we make sure, so what we're working on right now is how can Aaron train somebody in the Ministry of Health to have that capacity, and then we cascade and recognizing that that's a real investment. But absolutely the idea would not be that it would stay. The idea would also be that it can be used for exactly as Gregoire pointed out, you know, multiple approaches, whether that's early warning or other, and that is centralized as well. Yeah. It's a bit of a process still. Great. Okay, so I am aware that we are right on time and it's the end. So I did put a plug and I will send an email as well. I mean, this is something that we're pretty passionate about, and I think it could be a great contribution to improved IOA, and Gregoire really like how also IOA can improve health information system. So it's really a strong relationship to be working on. So please do reach out if you have either a case study, you'd like to build a case study, you'd like support, you'd like more information. We are absolutely available for that. We continue to work on this as a kind of sub project. So please do be in touch. We will share out minutes, we will share out presentations as well, and contacts. And then we will also send out next week the update for the following call. So thanks everybody and have a wonderful weekend. And thanks Gregoire and Aaron for the presentations, really appreciate it. Happy weekend, everyone. Take care.
Thanks, everybody.